GI Burst Part 3. AST and ALT levels greater than 1,000 should only be seen in the following conditions. What conditions can give you an AST and ALT level greater than 1,000? Number 1, acute viral hepatitis. Number 2, shock liver. And number 3, toxin related, specifically acetaminophen or Tylenol. Now, another condition that can give you a pretty elevated AST and ALT level is autoimmune hepatitis, but it's still not going to be anything like acute viral hepatitis, shock liver, or acetaminophen toxicity. And by the way, acetaminophen is notorious for causing extremely elevated levels of aminotransferases. So anytime you see an AST and an ALT level greater than 5,000 IUs per liter, or even upwards of that, we're talking like 10,000 IUs per liter, always think acetaminophen, get a Tylenol level no matter what. Next, model for end-stage liver disease, the Meld Score. Model for end-stage liver disease. What are the components of the Meld Score? Components of the Meld Score are, number 1, bilirubin level of the serum, number 2, INR, and number 3, creatinine. And then the last component is whether or not the patient has had dialysis at least twice in the past week. So these components you have to know. Then from here you can plug the numbers into the Meld Score calculator to get your Meld Score. Now, at what Meld Score will you see a 3-month mortality rate of roughly 50%? So what Meld Score confers a 3-month mortality of roughly 50%? This is a Meld Score somewhere between 30 and 39. It confers a very poor prognosis, having a 3-month survival rate of just 50%. All right, name as many causes for acute pancreatitis that you can. Go. Causes for acute pancreatitis. Number 1, gallstones. Number 2, ethanol. Number 3, recent ERCP procedure. And number 4, hypertriglyceridemia. So those far and away are the most common causes for acute pancreatitis. And just a few other causes include trauma, steroids, infection, hypercalcemia, there's autoimmune pancreatitis, scorpion stings, hyperparathyroidism, hypercalcemia, and drugs. So we see it often in Crohn's patients that are taking azathioprine, steroids we already mentioned, and then certain HIV meds. So those are several causes for acute pancreatitis, but never forget about gallstones, ethanol, ERCP, and hypertriglyceridemia. So those are the most common causes. All right, how many liters of gastric content does the stomach secrete in a day? So the stomach secretes roughly 2 liters of gastric juices every 24 hours, and that's at a pH of like 1 to 2. So it's lots of just nasty acidic stuff that's being secreted throughout the day. And it's pretty useful to have a sense of this when you're dealing, well, especially when you're dealing with NG tubes. So in theory then, if the NG tube was set to continuous suction, you'd suction about 2 liters of gastric juices in a day. Now on intermittent suction, if the patient was not totally obstructed and their GI tract was working, you could expect less than 2 liters. So there's a few factors at play when it comes to managing an NG tube, but in the back of your mind, just remember that the stomach normally secretes about 2 liters of gastric juices in a day. All right, a patient undergoes upper endoscopy for epigastric pain and a duodenal ulcer is found. So what should be done? A duodenal ulcer is found. What do you want to do? Yes, you get a biopsy. Now let's say the biopsy comes back positive for H. pylori. So what's the next best step? Treatment, right. So you want to treat with number 1, a PPI, such as omeprazole, number 2, clarithromycin, and number 3, amoxicillin. So do this for 14 days. After treatment, what are you going to do? So you treat for 14 days. Do you want to repeat the endoscopy? No. So you definitely don't have to repeat the endoscopy for duodenal ulcers. Gastric ulcers, on the other hand, you probably should because of the risk of gastric malignancy. But duodenal ulcers, you don't need to repeat the endoscopy. So after treatment of H. pylori, you must, absolutely must, confirm eradication. And I don't care what they're doing out in practice, but according to the boards, you got to do it. So if the patient had a duodenal ulcer, you can confirm non-invasively using either a urea breath test or a stool antigen test. Now, the one caveat to the urea breath test is that the patient should be off the PPI for several weeks prior to doing the test. And that's it. So long, goodbye.